How does Ferritin Tests, relate to the iron saturation test?
Well, they're related. The two are related. They're different tests, but they're kind of hand in hand. And so if one is elevated, often the other is elevated.
Is one more accurate than the other?
No, they measure different things. But ferritin has been considered a test that measures your total iron burden. Transferrin saturation was around a lot longer. Like, it's been around since the 1950s. Ferritin was developed in 1976 in Australia, in the lab that I worked in with Professor June Halliday. So it would be more typical to monitor the ferritin falling with your phlebotomy. The transferrin saturation often stays elevated during phlebotomy treatment. One of the things that I'm going to emphasize, and show you a slide that emphasizes this in a moment, that most people with an elevated serum ferritin don't have iron overload. Okay, I'm going to say that again. Most people with a high ferritin don't have iron overload. This is a real shock to patients in my clinic. Yeah?
How are you defining iron overload?
That's a good question. Because if you want to really dig into it, you have to get into something pretty invasive. And when we studied this in the 1970s and 80s, we used to do liver biopsies in everybody. So we've published papers where we've done 800 liver biopsies on people like that. We've done liver biopsies on people that have an elevated transferrin saturation and normal ferritin. We've done people that have high ferritin and normal transferrin saturation. We've done people that have both tests elevated. And if you have a high TS and a normal ferritin, we've never seen iron overload in the liver biopsy. Now the liver biopsy has gone from a diagnostic test, it used to be, to a prognostic test. Because we know if people have cirrhosis, they're more severely affected and have to be monitored more closely than people that don't have cirrhosis. The number of biopsies at our center has dwindled dramatically. We went from 200 biopsies a year in my clinic down to less than 10 last year. That's mostly because we have brought in a new piece of equipment called the FibroScan. It's an interesting machine. It looks like ultrasound. It's actually hepatic elastography. And it came from France, from the study of cheese, French cheese. And they wanted to know if French cheese was hard or soft inside before it was sold. So somebody clever there adapted it to livers. And if you come to my liver clinic now, pretty much everybody has a FibroScan because it's non-invasive and it'll tell you whether your liver is hard or soft. And hard is bad and soft is good. And there's gradations in between.
Liver function tests with blood work versus biopsies. Like, obviously biopsy is better then?
Oh, biopsy is much more informative. Liver enzymes, first of all, we don't like the term liver function test because they're not really measuring function. AST and ALT are often referred to as that. Those are usually normal in hemochromatosis. So that's why the person never gets to the liver clinic. So if you see somebody coming in with very high AST and ALT and high ferritin, they almost never have hemochromatosis. They almost never have iron overload. They have an inflammatory disease to be determined, sometimes not determined.